Hello, I'm Dr. Kim Yong-jin. Among various bone graft materials, autogenous bone graft material has less side effects and better ossification and good healing. Many do not prefer to use it. However, if you can harvest the bone, it has very good prognosis. So in this lecture, let's look at how to apply the autogenous bone graft technique that is easy to use. First, there are many benefits when it comes to autogenous bone graft material. In it, in some cases, live osteoblasts are included, and the patient is free from transmission of infectious disease, which is a problem when you use xenograft or allograft. And the prognosis of bone regeneration is very good, so it is considered a gold standard. Depending on the donor site, extraoral and intraoral donor sites exist. In a local clinic, it is not easy to harvest the bone extraorally, so mostly it is obtained in the mouth. So this is extraoral donor sites, which is not used very much clinically, so let me skip it. We can take bone in various areas: maxillary tuberosity or anterior nasal spine can be the donor sites. In the lower jaw, ramal bone and chin bone can be harvested. Near the implant placement site, if you find bulged bone or easy to access maxillary tuberosity near the implant placement site, they can be easily harvested. Depending on how autogenous bone is harvested, we can divide it into the block type and the particulate type. If it is harvested as a block type, it should be fixed with a screw. If the type is particulate, you can mix it with other graft material or it can be used in a layering technique. In the tuberosity, using the chisel, just one chisel, very simply, cancellous bone and cortical bone can be easily harvested from the maxillary tuberosity. The bone there is not very good. To cut the bone, you don't need to use a saw or a drill. You can easily harvest the bone. Using the Osstem chisel and mallet, it can be cut. Sometimes there can be some bulging in the maxillary tuberosity. You can cut it like that to reduce pocket formation behind the most posterior implant crown. Simply put, we can secure enough space for the crown, and additionally, we can harvest the autogenous bone from there. A block bone is harvested, or using a bone wronger, the bone can be harvested in particulates from the bulged bone or the tuberosity region. Let me show you a case. At number 16 and 17, 2 implants were placed. Extraction was done in another clinic. On the panorama, there is radiolucency observed at position 16. That means that there is a bone defect or the bone quality is poor. CT was taken at number 16. Bone defect is observed on the palatal side, not the buccal side. I suspect the palatal root had severe perio disease at the time of extraction. The palatal wall collapsed. It is very hard to regenerate bone palatally because the buccal gingiva is much thicker than the palatal side. It is very difficult to maintain the ideal space. The palatal flap cannot easily be pulled coronally. So this is a very unfavorable environment for bone grafting. So we need to use graft material with excellent bone regeneration potential. I thought creating ideal contour like this would be helpful for long-term prognosis of implant. Pre-op photo, soft tissue healed very well. And the flap was raised, and you can see the bone bulge buccally. If the bulge exists, to make a favorable peri environment for better cleansing, around the prosthesis of an implant, we decided to trim it. A little bit of indentation is made using the chisel and the mallet. It is cut off in a block type to make it particulates. A bone mill or crusher is used to break it. After the preparation, 2 implants were placed at 16 and 17. As we expected on the CT, the palatal side of number 16 implant showed the bone defect. The palatal side is exposed. We decided to do GBR using membrane and bone graft material. The membrane is positioned and below the membrane. On the palatal bone defect, the harvested autogenous bone particulates are put. The bone graft material is covered with a membrane and primary closure. As the bulged bone on the buccal side was cut off, the primary closure on the palatal side was easy to do. Panorama after the placement, PA. After about 16 weeks, as I said before, if you use autogenous bone graft material, bone can be regenerated fast. Before the second surgery at around week 16 to check the bone regeneration pattern, CT was taken. At number 16, palatal bone was regenerated ideally, and the second surgery, flap was opened like this and checked. At number 17, GBR was not done. Cover screw was easily found, but at 16 where GBR was done, the newly regenerated bone is covering the cover screw. Abundant autogenous bone was used, and within 4 months, the bone turned into new bone for the patient. So autogenous bone or allograft can be replaced by new bone of the patient. The new bone is removed to find the cover screw, which is removed, and healing abutment is connected. Primary closure is achieved. You compare before and after. So if you look at here, sometimes we are urged to use autogenous bone. As long as we can harvest it, then we will have a very good prognosis of bone grafting. Still, we are not sure about additional surgical site, but if autogenous bone can be harvested near or at the implant placement site, the bone regeneration can be very effective if you use the autogenous bone. Before and after, the wide palatal bone defect is turned into an ideal contour like this after using an autogenous bone graft. At the time of implant placement, despite the excellent healing pattern of autogenous bone graft material, it is not widely used because the supply is limited. When you want to harvest a lot of autogenous bone, you need to have another operation site, which is burdensome. That will increase the discomfort on the part of patient. So this is not widely used by the clinicians. Another reason is that additional treatment is required using bone mill or bone crusher after harvesting the bone in a block type. So you need to be equipped with the instrument, and you need to think about how much the instrument can be used. That's why people are reluctant to harvest the autogenous bone. Let me introduce auto bone collector, a drill developed by Osstem to harvest autogenous bone. It is composed of a drill and a stopper. Cortical bone is drilled, and the drilled debris would be collected between the stopper and the drill, and the harvested autogenous bone can be used without any additional treatment. These are the components. There are different diameter drills and the stoppers for the drills. The cortical bone debris drilled would be collected in the stopper. The bone ejector is used to take out the harvested bone from the stopper. The stopper is connected to the bottom of the auto bone collector. It is used at 5 to 6 RPM speed to take the cortical bone. Maximum drilling depth is about 3.8 millimeters. It doesn't cause damage to the bone marrow without causing bleeding, so harvesting can be done easily in the cortical bone. The harvested bone is like sawdust from plane. As it is harvested in a form of particulated bone, you don't need to use bone mill or bone crusher. It can be used immediately after harvesting. Before drilling, you can connect the stopper in the indentation area at the speed of 500 to 600 RPM. It can be drilled into the cortical bone. You need to stop when the stopper reaches the top stopper of the drill. As I said before, the drilling depth is about 3.8 millimeters. I usually take bone from ramus. Before, I took bone from chin a lot, but these days, for lower anterior, I use small one-piece implant like MS rather than two-piece implants, so GBR is used much less. In the lower posterior, I frequently use the autogenous bone harvested from ramus when fast and stable bone regeneration is necessary to fill the gap for immediate implant placement or when posterior vertical defect is severe. As you can see, for the immediate implant placement in the lower posterior, bone collector is used to harvest the bone from ramus. If you use an auto bone collector with the diameter of 7 pi, you can harvest the autogenous bone about 0.2 to 0.3 cc. You don't need to do any additional treatment because it is done with irrigation. If you need GBR in the lower anterior region, we can take bone from the chin, the symphysis. This is the initial auto bone collector model used in ramus. It had disposable plastic stoppers, but now it is made of metal and reusable after autoclaving. In this way, the autogenous bone can be harvested easily but not in large amount, but good enough to fill the bone defect around an implant. As I said before, we harvest the bone from ramus and chin. This is a paper comparing the thickness of cortical bone in the ramus and the chin, the symphysis, between Korean men and women. At the symphysis, the thickness of the cortical bone is 2 to 2.5 millimeters in men and 3 to 3.5 millimeters in ramus. In women, it's thinner, so it's below 2 millimeters in the symphysis and below 3 in ramus. We use the auto bone collector within the cortical bone because if we drill into the bone marrow, it will bleed and cause discomfort to the patient. As I said before, if you use the auto bone collector in the full depth, the drilled depth would be 3.8 millimeters, so it's much safer to use it in the ramus where the cortical bone is thick. If you use it in the full depth in the symphysis, bone bleeding can occur and there's inferior alveolar artery anastomosis, which will make bleeding more severe. So at the symphysis or chin, do not go to the full depth and stay within the cortical bone. In the ramus, there's no problem if you go to the full depth. You need to remember the tips when you use auto bone collector clinically. First, the cutting speed. If it is 800 to 1500 RPM, like the taper drill or the cutting drill, the harvested bone particles are too small. If you use a twist drill at 1500 RPM, the bone debris is very small. If the bone particle is very small, it will be resorbed even more. So proper size autogenous bone graft material needs to be acquired. For that, 300 to 600 RPM is guided, and I use 500 RPM clinically. In the cortical bone, I get the sawdust type particles in the size of 2 to 3 millimeters. The auto bone collector can use big diameter drills like 5, 6, or 7 pi without pre-drilling in the cortical bone. A drill may slip or bounce. To prevent that, they designed a 0.6 mm long center point at the end of the autobone collector drill. It stabilizes the rotation of the drill at the center. If you start rotating the autobone collector outside and put it on the cortical bone, it may bounce or slip. So you'd better stably insert the center point into the cortical bone before you step on the pedal to rotate it. One more important thing, the stopper should be perpendicular to the residual bone wall. Clinically, it is used with irrigation, so if there is a gap between the stopper and the residual bone to be harvested, the drilled bone would be drained out. So you need to approach the residual bone wall in a perpendicular way. We talked about the autogenous bone graft technique, which is easy to use. In conclusion, in the upper posterior region, a bone chisel or a bone wronger can be used to get bone from the maxillary tuberosity or exostosis. After that, you can use a bone mill or a bone crusher to break it into particles. In the posterior mandible, you can use the autobone collector in the ramus in full depth, and you can apply the cortical bone particles directly. In many cases, you need to fill a gap after immediate implant placement in the lower posterior. I believe the autobone collector is the best item for that. We place an implant in the bone defect area. We are struggling in choosing proper bone graft material. Without bone graft, the placed implant would not have very good prognosis and have various complications. I do not recommend that you absolutely need to use bone graft materials. But after having bone graft failures, or if autogenous bone can be easily harvested from near the implant site, there's no reason not to use the autogenous bone. So autogenous bone graft can be the first choice if it gives less discomfort to the patient and less burdensome to the surgeon. So the autobone collector is very useful in that respect. Thank you very much for your attention.